Hello everyone, welcome to 5 mark short note series. In this video, we will see about status asthmaticus. Status asthmaticus is a prolonged asthma attack that does not respond to inhaled bronchodilators or corticosteroids and may progress to respiratory failure. It is severe, life-threatening exaggeration of bronchial asthma that fails to respond to conventional therapy like the bronchodilators or corticosteroids. It represents the terminal phase of an uncontrolled asthma attack and requires immediate aggressive management to prevent a respiratory failure and death. It is most commonly seen in children, adolescents with poorly controlled asthma, and often precipitated by infection, allergens, or drug noncompliance. Affects 1 to 5% of hospitalized asthmatic patients, account for major pediatric admission with a mortality rate of 0.3 to 1%, common in school-age children and adolescents. Risk factors include poor control, past ICU admission, smoke exposure, and low socio-economic status. So, what are all the causes of status asthmaticus? Respiratory infections like RSV, rhinovirus, and influenza. Allergen co-exposure like dust, pollen, animal dander. Environmental triggers like smoke, cold air. Drug-related like NSAIDs, beta blockers, or steroid withdrawal. Poor compliance or inhaler misuse, emotional stress, GARD, and sinusitis in a pre-existing asthma patients. Pathophysiology is there will be release of histamines, leukotrienes, and cytokines, which will cause mucosal edema and airflow inflammation. There will be bronchospasm that narrows the bronchi by smooth muscle contraction. Mucus plugging will be there since there is a goblet cell hyperplasia and a mucus hypersecretion that block the small airways. Then trapping of the air through dynamic hyperinflation, pulses, paradoxes, and hypotension, which will result in respiratory muscle fatigue, CO2 retention, and acidosis. The clinical features which present earlier include dyspnea, wheezing, cough, chest tightness, tachypnea, prolonged expiration will be there, use of accessory muscles, anxiety and agitation will be there. In case of severe cases, there will be silent chest, that is no air entry, cyanosis and diaphoresis, pulses, paradoxes with greater than 25 millimeter of mercury, confusion and drowsiness, bradycardia will be there. And this indicates impending respiratory failure. Investigations include pulse oximeter, where there will be less than 92% of SpO2 and hypoxemia, arterial blood gas analysis, where it will show reduced PaCO2 in early phase and increased PaCO2 plus acidosis in late phase. Chest X-ray shows a hyperinflated lungs and it can also be used to rule out pneumothorax. PFR will be less than 33% of prediction and eosinophilia or infection might also be present. Coming to the differential diagnosis, foreign body aspiration will be there, but it will be sudden in onset and there will be unilateral wheeze. Bronchiolitis pneumonia will be there, but it will be associated with fever and local crepitation. Hepatic failure, there will be crackles and hepatomegaly. Anaphylaxis will present with rash and hypotension. Vocal cord dysfunction sometimes will present with inspiratory wheeze and normal ABG will be present there. So the management is to maintaining airway and breathing, high flow humidified oxygen of 5 to 10 liter per minute, nebulized beta 2 agonist like salbutamol 20 minutes for every 1 hour, and addition of ipratropium bromide 200 microgram for synergistic effect. IV hydrocortisone, magnesium sulfate, aminophylline if refractory can be used, maintaining IV fluid and avoiding overload. Mechanical ventilation for respiratory failure is indicated. Complications include respiratory failure, pneumothorax or pneumomyastinum, then hypoxic brain injury, metabolic acidosis, cardiac arrhythmia due to hypoxia or drug toxicity. With early recognition and aggressive management, recovery is usually complete. A delay or inadequate care may result in hypoxic injury or even death. Regularly inhaling corticosteroid use in case of asthma patients, avoiding triggers like dust, smoke, and allergens, education regarding inhaler technique, and home peak for monitoring and vaccination against influenza and pneumonia can act as good preventive strategies. So, status asthmaticus is a pediatric emergency requiring prompt oxygen, bronchodilators, corticosteroids monitoring, prevention through good asthma control and education. I hope you learned from this presentation. Thank you.